Hi guys, welcome to the Lifeproof Core Series Day 2. Hopefully you attended class. If not, this PowerPoint presentation will be something you're definitely going to want to watch. And we're trying a little bit new way of recording today, so hopefully this works a little better. I know the last one had some issues. So let's get right to it. So the day one recap. So what we went over in day one were a bunch of different concepts primarily, and one movement dysfunction that we went over, which was breathing. But one thing I wanted you guys to get out of that was to drop your diagnosis for the purposes of our class, right? You know, there are reasons that diagnoses are a good thing in the medical industry, but what I want you guys to do is to start putting responsibility back onto yourself instead of expecting for a healthcare practitioner to give you a quick fix, right? So, biochemical intervention like a pain pill or a surgery that's going to immediately fix your pain, right? We want to fix our pain from the root cause instead of, giving yourself a crutch that like a surgery that could potentially have negative side effects, or just expecting that this is going to change overnight. And likely, if you're in back pain, it's not going to change overnight. Second thing I wanted you guys to get out of that was the new kind of outlook on pain and pain science. And what we really wanted to get out of that is that pain is an output, or it's a perception of your brain. So the example we kind of went over in class with the video of Laura Mosley was that you have a stimulus, and that stimulus could be the exact same in two different people, or the same person at a different point in their life could react with either no pain or very intense pain, or different levels of intensities of pain, even though that stimulus is the same, right? And so it's really not a characteristic of our tissues that's causing this pain. It's actually the brain's response to the input, or to the change in the characteristics of our tissues. Let's say if you get cut by a twig walking in the brush, which was his example. So if we start to look at pain as an output of the brain, especially in chronic pain, which your body is kind of sensitizing and getting more and more of a reaction to this input or this stimulus, which probably is our poor motor mechanics and how we're moving our body. If we need to change that output and change that perception, then we need to change either the stimulus or the input, or we need to make our brain feel more comfortable with a specific stimulus or input. So start thinking about pain in those terms, and that will help you out as we go. Altering movement mechanics, we kind of went over. That's going to be our intervention to stopping pain and also becoming more efficient with how you move. Then we also went over our first movement dysfunction that potentially could be causing some pain, and that was breathing, and that's kind of the chest versus belly breathing that we talked about in class. And we generally want to promote the belly breathing, or directing our breath downward rather than directing our breath upward. And remember, that depends on how you're engaging the diaphragm. Every breath is using the diaphragm, but if you direct the diaphragm so that the rib cage flares outward and the chest expands, you can facilitate altered mechanics through the spine, especially actually through the lumbar and the thoracic spine, where we might facilitate an anterior pelvic tilt, which builds a really big arch through the low back. And then up through the thoracic spine, you could exhibit excessive flexion, right? That kind of hunched over posture where the shoulders round forward, and the scalenes, which are the muscles on the inside of kind of the neck and the collarbone and the chest musculature, all can tighten up and again facilitate poor postural positions that then become new normal. And over time, remember, maybe that's that root cause, or that's that stimulus, is the poor posture. And that's all being facilitated by the breathing. So if we change our breathing, potentially we can change the mechanics through the spine, and potentially that's going to give your brain a different input or help it perceive that there's no longer danger there to help us get out of pain. So that's that. And this model on the right there is talking about that joint by joint approach, which we're actually going to go over in the next slide. So if you need to come back and check out that picture again as I'm talking about it, feel free. So this next slide, we're going to go over our second dysfunctional movement, or movement dysfunction that could be occurring, and that's mobility restrictions. So we already had breathing dysfunction, and now we've got mobility restrictions. So remember, if we think about that joint by joint model where each consecutive joint likes to be either mobile or stable, you could imagine then that a mobility restriction, especially at a joint that prefers to be more mobile, can cause altered movement mechanics. Our bodies are kinetic chains, right? So if even starting at the big toe, right? If we have limited big toe dorsiflexion, which means the big toe can't bend very far, as you go, even just in, say, your gait cycle, right? If you have a limited range of motion there, as in passively that joint just can't move any further, then that's going to alter the responsibility of the midfoot. Remember, the midfoot likes to be stable. And if we can't get enough dorsiflexion out of that big toe, potentially we pick it up in the midfoot that then becomes more mobile, right? Which is then changing some of the responsibility of that joint. And then the next joint, the ankle, right, likes to be very mobile. Potentially that ankle then wants to become more stable to make up for the lack of stability at the midfoot. So your body then can start this chain effect of compensations where even starting at something as simple as the big toe, which turns out is not so simple, can truly affect everything up the chain. Okay, so that's the joint by joint approach. Tensegrity is a concept coined by Tom Myers, who is he's the founder of a company called Anatomy Trains. They do a bunch of educational seminars across the world, and kind of touted as a leading mind in fascial, really fascial work. I don't know what else to call it. But what he was able to do was he tracked these, what he calls anatomy trains. Some people may call them fascial lines or fascial slings, but basically he was able to track the fascial connections. Remember, the fascia is connective tissue that surrounds the musculature and connects. It's basically connective tissue, right? It connects a lot of things in the body and helps different organs to really facilitate and articulate with each other. So the concept of tensegrity says that if you have these big long chains of fascia, kind of similar to how I described our body being kinetic chains, but talking about more like the skeletal system almost there, or having the joints be able to move. So if you factor in now these fascial connections that run along those same skeletal connections, if you have one section that is too tight, then that is going to be pulling on the next section of fascia. So think in between the joints, right? So if your big toe, if the fascia in the musculature that crosses that plane of the joints in the big toe, if that is too tight and pulling, then that can then affect the fascia that crosses the midfoot, which can pull and alter the next joint position, which then in turn can pull and on the musculature of the calf, and then on the musculature of, say, the hamstrings and the glutes, and how it crosses through the low back and the musculature of the low back, and so on and so forth. So if you think about it that way, you truly, again, just like the joint by joint approach, truly can have an issue, let's say, in your big toe in terms of lacking proper mobility of the fascia that can then pull on everything up the chain and alter the movement mechanics from there. The last thing, length-tension relationship, that is potentially a little bit more on the performance spectrum, but it basically says that the overlap of the actin and myosin fibers in the muscle would prefer to be at this perfect length that then can create the maximum amount of tension or force as the muscle contracts. So if those fibers are lengthened and are not overlapping as efficiently as they could be, then the ability of the musculature to contract is going to be less optimal, if that makes sense. So those are the concepts on mobility restrictions and why they matter. We are going to go over in class today some hip mobility screens. So there are a bunch of, and just like I said, the big toe even could factor into lower back pain. So really we need to have optimal range of motion at all our joints, but we're going to focus on a select few that I've found with my work tend to be big players in the lower back pain and core function topics. So hip flexion, you're going to do 3 screens. You're going to do a hip internal rotation, hip external rotation, and active straight leg raise. The internal external rotation, you're just going to be lying on your back, and a partner, just like in this photo here on the far right, is going to move your limb, and they're going to keep the knee directly above the hip joint. And they're going to get one hand on the knee, one hand on the foot, and they're going to rotate and see how far that foot travels in the internal plane for the hip, which would be outside or away from the body, and then in the external plane for the hip, which would be moving it toward the midline of the body. And ideally we want about 45 degrees in both planes. Now a lot of you guys are going to find that you're limited with hip internal rotation. And that's been a finding that I have found consistently with people, and it also just happens to be a clinical risk factor for lower back pain. And it definitely can affect your movement patterns for sure. A squat is a big one. If you lack hip internal rotation, you're going to be much more comfortable in a very wide stance with your toes pointed out squat, which is all fine and dandy, but we don't always squat from that position. So check those. Make sure that you've got 45 degrees of motion on both sides. And if you don't, then we're going to learn a little bit later how we can work on that. The active straight leg raise, that's pictured there on the left of the pictures, and that's from your back. You're going to be laying down with your feet together, your toes straight in the air, and you're going to raise one leg, keeping both limbs straight, with the knee locked straight as high as you can, and then holding it at the top. And if you can get the bone of the ankle on the raising leg, that malleolus there, if you can make that pass the kneecap on the down leg, then we say that that's pretty functional. In this image here, the guy is dropping his stick, the screener is dropping his stick at about the midline of between the knee and the hip. And if you're able to pass that marker with your leg, then we would call that probably very good mobility range of motion. The difference between this active straight leg raise and the two below it, that hip internal and external rotation tests, whereas the active straight leg raise is an active test, just as it implies. Therefore, we are no longer just checking mobility, we're checking for motor control dysfunction, which usually arises in this test at the trunk. So if you can't keep your pelvis in a more neutral position, or your lower back pushing into the ground with your core engaged as you raise this up, your leg up, likely you're not going to get that leg quite as high. So if your partner then can come over and as you're raising that leg in the air, asks you to clamp down your core, and then they move that limb up further, if there's a significant increase in the amount of distance that it goes, you're likely looking at a dysfunction, a motor control dysfunction through the trunk. Okay, we're going to talk about that stuff much more in the next session. All right, but for now, we're more so concerned with passive range of motion. So what I want you to get out of that, though, is that if that partner comes over and moves the leg upward after they ask them to clamp down the core, and that leg does not travel any further or very minimally, and that leg also happens to be low enough in kind of that segment where we would consider dysfunctional range of motion, then that is a big risk factor for, or it is telling you that you are lacking the ability to flex the hips, okay? And conversely, that down leg needs to stay in extension. So if you're noticing the down leg is wanting, the knee is wanting to bend or the toe is wanting to turn out, you could have some mobility restriction as well through the anterior portion of that down hip. So hopefully you're in class for that, because that can get a little bit complicated. So if you have more questions and you are not in class, please let me know and I will address them. Some other honorable mentions for areas in relation, mobility restrictions in relation to the lower back pain, the thoracic spine, again, so those two joints above and below the pelvis low back, right, it would be the thoracic spine, or that midsection of your spine that likes to be very mobile, right? If it can't rotate both directions sufficiently or extend and flex, generally people are better at flexing, because that's that hunched over position we like to find ourselves in as we're typing away on computers and things like that. We tend to have more trouble going into extension. So if we're lacking mobility there, remember, less degrees of motion in a joint that likes to be mobile means if you want to create a specific movement or complete a task that requires you to get in certain positions, then if the thoracic spine or the hips are too restricted, then you're going to have to recruit mobility from another joint, and potentially that joint is going to be the pelvis lumbar spine that does not like to be quite so mobile. Ankle mobility tends to be a big one. So moving on. Mobility correction interventions. So these are all different things that you can work on to correct if you do find some mobility restriction through your hips, or if you get into the thoracic spine or the ankle or big toe, all those joints, right? Then these are things that might work for you at increasing your range of motion. First being manual therapists. It's where a lot of people think to turn to. So physical therapists, chiropractors, massage therapists, just to name a few. But basically just describes any person that's actually going to put their hands on you and facilitate the tissue via their own hands, right? So if physical therapists do mobilizations of joints as well, as do chiropractors. Chiropractors call them adjustments, and physical therapists tend to call them mobilizations, which is something that might go above and beyond soft tissue work, where they're actually manipulating the positioning of a joint if there's more of a mechanical restriction. If the restriction's occurring via soft tissue, and again, this is something that an expert like a physical therapist, chiropractor, or a movement specialist like myself might be able to help you out with, to figure out, maybe do you need more of a joint manipulation, or maybe do you need some soft tissue work, or potentially the answer is both. And remember, soft tissue is going to be leading into that joint and affect the joint positioning. So a lot of the times, if you mobilize the soft tissue, you can rearrange on your own. It just won't be as instant, that joint positioning. Number 2, self-myofascial release. That's like foam rolling, that I'm sure a lot of you have heard of. Foam rolling doesn't have to be a foam roller, though. What I brought into a bunch of tools into class, right? We had lacrosse balls and something called orb. That was like a giant lacrosse ball, and there's like rolling sticks and all sorts of different shaped rollers, right? So basically what you're doing there is you're doing what the manual therapist is doing in terms of soft tissue work, but you're doing it on yourself. So I always remind people, if you want to increase your mobility and you have a true soft tissue restriction, it generally takes time. Every now and then I have somebody come around where it's like, okay, we foam roll the spot that we're looking for, and boom, they all of a sudden become elastic, and they're like Stretchy McGee, and they can move all over the place, and they do that a few times for a week or two, and they're good to go, right? Most people, it doesn't work like that. Me, for example, I was working on some posterior chain restriction, and it took me months. And what I finally found out was that I had to commit to this stuff at least once a day to be successful and to see an increase in your range of motion over time. So my point there, though, is that you're probably going to spend a whole lot of money with a manual therapist if you're looking for specifically increasing mobility and range of motion. So that's probably not practical. What those manual therapists do well, though, is pain mitigation. So if you're in pain, you can go to somebody like them, and they can help you get you out of pain quickly. And that's why they're so popular, and you've heard about them. So that's all good stuff too. So myofascial release, we're going to go over some of that. Stretching, a bunch of different forms of stretching, but static and PNF stretching, those are two different types that can be seen. I tend to use the PNF stretching as often as I can and avoid static stretching. So, and the reason being is that PNF stretching just tends to be more effective. PNF stretching is basically a bringing a joint through its range of motion so that you feel stretch, and then contracting against the stretch. So if it's your hamstrings, you're like bringing yourself into a hamstring stretch, and then you contract the hamstrings the other way against resistance. So like if you're holding your leg up with a band, or if some person was holding your leg up, they would contract against that hand or band for 4 seconds or a short period of time, and then they would relax, and usually that limb can then travel further into a range of motion. So it's important to note some of the mechanisms of how this stuff works. So stretching and myofascial release likely, which we'll go over in the next slide, you're not like actually stretching the tissue. It's not like you're physically pulling things apart, which a lot of people think. The research is showing that it's more of a stretch tolerance. So your brain is getting more comfortable bringing that leg to a specific, or bringing that limb to a range of motion, or joint, I should say, really. And you have these proprioceptive nerve endings that track that, and they track your positioning in space. And when the joint goes into an extreme range of motion, right, which might be limited for some people if you've lost mobility, then those receptors are going to fire off and go, I don't trust you going outside this range, so I'm going to tell you it hurts, so I'm going to have you stop, right? Which shows you why PNF stretching is effective, because it's really getting at more so the nervous system. You're kind of tricking your nervous system by contracting at end range and then relaxing and allowing yourself to get further. Voodoo floss is another thing you could try, and that's all about fascial glide. It's basically this elastic band that you wrap around the area you're trying to mobilize, whether it's a joint or just strict musculature running across, or the bands of musculature. It doesn't necessarily have to be over a joint. And fascial glide, remember we were talking about fascia earlier, right? It's the connective tissue, it's covering muscles and things like that, and there are layers of fascia that need to articulate over each other, and if they can't slide very well, and you guys can't see this, but I currently have my hands stacked on top of each other, and I'm sliding them back and forth to kind of demonstrate that. So imagine that in your head. So if they're sort of sticking, they don't slide very well, your movement's going to be limited. And a great example is this: when you get out of bed in the morning, you will have, and you feel kind of stiff, right? You've been immobilized for long enough that those fascial layers have kind of stuck together. There's a pretty famous scientist or MD in the field that calls it fuzz. Not the most scientific term, but that's how he deems is what's happening, is that those fascial layers are kind of just sticking. So by wrapping it with compression, so kind of extreme compression, and then moving around, you're able to then improve the glide of the fascia. And then the last thing there is group courses. So you can go, instead of doing all this stuff on your own, you can go into a group course that would guide you through mobility strategies such as what yoga might do. Kin stretch is a kind of an up-and-coming thing that I may potentially start teaching soon, so keep an eye out for that. So let's move on again, and we're talking about hip mobility interventions, myofascial release specifically, that we briefly mentioned in the last slide. So let's talk about that mechanism of that now, and it's really, they're not quite sure yet how myofascial release really works. What is probably pretty clear is that they no longer think that it's a mechanical mechanism. Like, you're not breaking up tissue necessarily, that a lot of people again think that they're doing when they're rolling. It's likely more a neurophysiologic mechanism affecting nerve endings in the fascia and the muscle and the musculature that are basically being down-regulated. If they're tight, they're overactive and they're engaged and stiff. And then likely with that pressure and that stimulus from the roller, they get to relax, down-regulate, and let go. The other thing that foam rolling is good with is just pain mitigation. So not only just working on mobility, but also reducing pain. So if you have a painful area, you can try just slapping the roller right onto that area and getting pressure down onto it, and letting it relax and release via your breathing. And it is quite possible that that area could then feel a little bit better. Likely a similar mechanism, neurophysiologic, and also reducing DOMS, that's delayed onset muscle soreness, that they used to say was, it was probably lactic acid accumulation. Now they're saying it's probably not, probably microtears in the musculature that are inflamed and causing the pain reaction. And rolling can tend to help with DOMS, and likely again via neurophysiologic effect of, the pain gate theory is a potential where you're just giving a competing stimulus in the area that's uncomfortable or in pain, and those same nerve endings go to your brain and back, and it's like walking down a crowded hallway versus a non-crowded hallway, right? Where you could run down a non-crowded hallway, but you would have to bounce around people and move laterally, and it would take you a lot longer in a crowded hallway to get down. So that's the pain gate theory that says if you overload these nerve endings with competition, you can decrease somebody's pain status. So potential as to maybe why it works with the DOMS and why it works with pain mitigation. And likely it probably stimulates some blood flow to the area as well, and that's another potential mechanism. But really, they're not quite sure yet. There's still needs to be a lot more research done. But at the end of the day, what they do know is it works in practice, right? Physical therapy, chiropractors will likely recommend it. I recommend a lot of this stuff, and we all as professionals in these industries see firsthand the changes in range of motion, the reduction in pain, the reduction in DOMS, things like that, that it can benefit with. So, and then one last thing. So you guys are going to go into some myofascial release, and you're going to release all areas around your hips, but you can use these tools to release really anywhere in your body that might be tight. One big thing I want you to know about that is I would rather that you find those trigger points as you're rolling and then stick on them. Okay, and stick just as soon as you find one, we'll screen your area that you're rolling. And again, you don't want to be on bone. You don't want to foam roll or try to release bone. It's just not going to do anything. It's likely going to be uncomfortable and painful, and might bruise yourself. So be on soft tissue. Screen the area that you're rolling. Find a trigger point, which is a point of kind of uncomfortable sensation, really. Stay on it. Work on your diaphragmatic breathing that you practiced all last week, and then let that tissue relax, and it should be able to relax down for you. The other thing I should mention too is there are all sorts of different sizes and shapes of foam rollers. So you're going to play around with intensity in class of these different rolling mechanisms. The greater the surface area, the less intense. The smaller the surface area, the more intense. The firmer the object, the more intense. Less firm the object, the less intense. So you can play around with those different things. Ultimately, you want something that's a little bit uncomfortable, that you can still breathe through and relax, but not so uncomfortable and painful that like you're like, I got to get off of here in 10 seconds because it's just so painful. So work on that at home, and I'll send you in an email a list of certain areas that you might want to target with the myofascial release. The next thing is hip mobility, another intervention called the 90-90. So you can, foam roll, mobilize soft tissue. This 90-90 attempts at getting at kind of the deepest layers of tissues in there, and that's the joint capsule, and really trying to get that joint capsule to turn. So this really helps with internal and external rotation of the hips. You can see this model here has his front, which is his right leg, in external rotation, or right hip, and his left hip is in internal rotation. And for most of you, that internal rotation or internally rotated leg, that one that he's got on his left side, is going to be the really uncomfortable one. And what's going to happen is your torso is going to shift away from the pelvis. Like the upper half of the torso is going to shift away from that left leg to feel comfortable. So you've got to drive off that right hand, try to get yourself over your base of support, which is your torso, and put that hip into more internal rotations. You're going to try to sit that left hip down into the ground, and you're going to breathe. Deep breaths diaphragmatically, and you're going to feel a pinching sensation in that hip, and that's okay. That's kind of normal. You're basically bringing that hip into as much internal rotation as possible, and then it's a little bit more, and your brain is telling you about it. It's going, I don't like that. I'm going to fire off some pain receptors. So work on that guy, likely for internal rotation if it's limited, or you could work on it for external rotation. So I should be getting some videos up of these exercises as well pretty soon here. Cool. So that is your last one for the day. So we really worked on mobilization. So especially for those in back pain, that's very important. If you are looking for performance variables, mobility is also very important. It will change your movement mechanics. It will make you be less efficient at moving, increase your risk of injury potentially by decreasing the mobility of the joints that would like to be mobile. So work on those things this week, and I will see you again this weekend.